We can start.
Okay, so we're back with our rapid revision series, and the topic for today is conjunctiva. Uh, just one long question. Describe clinical features and management of trachoma. Now, and some short questions including subconjunctival hemorrhage, vernal. That's okay. That's vernal conjunctivitis, flictannular. We talked about flicten in the last class. Ophthalmia neonatorum, pannus, trachoma again, and diplobacillary conjunctivitis. So Oracle provides you with recorded classes that you can access as per your convenience anytime, anywhere. Then live classes, which are in real time, and they enable interaction between the students and the teachers. Practical sessions for your practical exams, an express exam module which covers the entire syllabus in 20 hours, and a book set. The foundational classes they provide an extensive coverage of the subject, and you have the freedom to choose what subject, when you want to revise, what teacher you want to, you know, choose. So you have all that freedom in the foundation classes. Then the live classes are a 45-day thing, and they are for basically for your first prof. And these classes cover the past 10-year question papers and also give you the most anticipated questions. Then there is the express exam module, which covers your syllabus in less than 20 hours. It's a quick revision of everything. There are one-to-one doubts clearing sessions. There is this hard copy set that is provided to you, a question bank, and practical sessions, which are also live classes, which enable you to prepare for your practical exams. And then there are these four subscription plans. The foundation plan is for 3 months, the advanced learning 6 months, complete learning plan for 12 months, and the ultimate MBBS plan, which is for 4 years. So you can choose accordingly. Also, you can use the coupon code for getting a discount on the subscription. So, coming to the topic of the day, that is conjunctiva. Okay, right. Now, as you know, the conjunctiva is a thin, transparent mucous membrane that lines the surface of the eye and the eyelids, right? So this is a closed eye. Okay, this structure over here is a closed eye, and you see that the conjunctiva is lining the inside of the eyelid as well as the fornices and the surface of the globe, right? Here. This is a transparent membrane that lines the entire structure, the eyelids on the inside and the globe. It is made up of stratified, non-keratinized epithelium. It is thickest at the limbus and thinnest at the fornices. So the four in the figure is actually the fornices. So what is important about the conjunctiva is that it is covered by a tear film. Now the tear film has three layers. You must know the three layers. So the innermost mucinous layer is secreted by the goblet cells of the conjunctiva. The middle aqueous layer is secreted by the lacrimal glands, and the main lacrimal as well as the accessory lacrimal glands, and this is the thickest layer. The outermost lipid layer secreted by the meibomian glands, which helps to prevent the evaporation of the tears. So here in figure 1, that's the marginal, in number 1 is the marginal conjunctiva. Number 2 is the tarsal conjunctiva because you have the tarsal plate there. 3 is the orbital conjunctiva. These are all parts of the palpebral conjunctiva, right? 4 is the fornicial conjunctiva. 5 is the bulbar conjunctiva, and 6 is limbal conjunctiva. Okay, so they're all according to the locations. Just different names being given. The structure is the same, obviously. So, conjunctival flora. Now, the conjunctival sac is never free from microorganisms, but the environment is hostile for the proliferation of these microorganisms because of properties of the tear film. What properties? The tear film contains lysozyme. Then the tear film, there is evaporation, some evaporation that is happening. So, it is maintaining a cool environment, right? So that cool environment is hostile for proliferation of these microorganisms. So they're just present in the conjunctival sac as commensals. You know what commensals are, right? So these are non-pathogenic commensals, staph, diphtheroids, propionibacterium, Neisseria, corynebacterium, etc. Now the pathogenic ones, these are the ones that are pathogenic. Okay. Now remember, there are certain bacteria. You can get a question in your viva that there are certain microorganisms which can invade an intact cornea. So of these, which one of these is capable of invading an intact cornea? Remember, Neisseria, okay, and diphtheria, yes, cornybacterium diphtheria. There's xerosis mentioned here, but cornybacterium diphtheria can invade an intact cornea. Besides this, there are others like Haemophilus aegypticus and Pseudomonas. Okay. Now, anything that happens in the conjunctiva, it elicits an inflammation, and this inflammatory reaction is usually seen in the palpebral conjunctiva, that is the one on the eyelids. So there are only two types of inflammatory reactions, follicles versus papillae. You must know theoretically and clinically how to differentiate between these two. So what you see here, see, these are white dots which look like sago grains, right? Yellowish white round elevations about 1 to 2 mm in diameter, sago grain appearance. And what are they? They are actually aggregations of lymphocytes in the subepithelial adenoid layer. Remember, a follicular conjunctival reaction is not seen in newborns. Now, papillae, what about papillae? Papillae are actually, there is no picture here. I'll show a picture in the subsequent slides. So, papillae are glomerulus-like bunches of capillaries growing into the epithelium, right? Giving a velvety appearance. So, this is sago grain appearance. This one is a velvety appearance. And what actually happens is that there is hyperplasia of the normal vascular system. So, basically, the papilla is something like this. This is the epithelium over here. And here you have a hyperplastic blood vessel over here, okay, in the within the structure. This is what a papilla looks like, okay. Whereas follicles are nothing but aggregations of lymphocytes, okay. These are aggregations of lymphocytes in the subepithelial adenoid layer, okay. Subepithelial, right? So it is here, the connective tissue layer, okay. Now, broadly, conjunctivitis can be divided into infectious and non-infectious. The infectious conjunctivitis can be again divided into acute versus chronic, and non-infectious can be any of these. Okay, so we'll be discussing each of these briefly. So acute infectious conjunctivitis, you can get it as a short note, you can get a long question. Now it could be bacterial, it could be viral. Viral is definitely more common. Okay, viral conjunctivitis is more common than bacterial conjunctivitis. But bacterial conjunctivitis is more causes more of morbidity. Okay, so a bacterial conjunctivitis would have a purulent or a mucopurulent discharge, that is yellowish white or yellowish, mostly caused by Staph aureus. Okay, conjunctival congestion, mucus flakes, discharge, chemosis is nothing but edema of the conjunctiva, and colored halos. Again, remember the Fincham test used to differentiate between halos of glaucoma versus cataract. And what about conjunctivitis? The colored halos of conjunctivitis, you don't need a Fincham test for that. The colored halos would disappear when once you wash out the mucus flakes, right? So just use saline to wash out the mucus flakes, and the colored halos would disappear. And the rest of the features are present in basically any type of conjunctivitis, only the discharge may be different. Okay, the discharge in case of bacterial is either mucopurulent or purulent, whereas in viral usually the discharge is watery or serous. Same in allergy, but in allergies you also have a stringy discharge, it's string like white rupee discharge. Okay, that is very characteristic of allergy. Then there is hyperacute conjunctivitis caused by these deadly organisms, Neisseria, Staph aureus, some beta hemolytic streptococci, Haemophilus aegypticus, and gram-negative bacilli. Treatment, usually broad spectrum antibiotics are given and it responds to that. So these are some of the broad spectrum antibiotics, and an ointment should be applied at bedtime. Eyes should not be bandaged. What does bandaging do? Bandaging prevents the evaporation of the tear film, okay, and accumulation of all that debris, right? So it promotes infection. So do not bandage the eyes. Sunshade or dark goggles, some people might complain of, worsening of the foreign body sensation, or they may actually have photophobia if there is corneal involvement. So a dark goggle can be recommended. Avoid contagion by maintaining hygiene, ocular hygiene as well as hand hygiene. Okay. Some other agents that can cause infectious conjunctivitis include chlamydia and viral. We'll be discussing those. So, what about chlamydia? The name of the species is Chlamydia trachomatis. Now, there are serotypes, okay? So, serotypes D to K cause inclusion conjunctivitis or swimming pool conjunctivitis, right? And serotypes A, B, and C cause trachoma. Otherwise, chlamydia is known for oculogenital infections, and the genital infections include the following. Okay. Now, diagnosis of chlamydia requires these tests. These are some of the. So, the simplest among these is just simply a GMSA staining of the conjunctival smears. Okay. So, chlamydia is not a typical bacterium. That is why it is being taught separately. And besides that, chlamydia has its importance in the fact that trachoma, which was once an endemic disease in India, very, very endemic, very, very common, but has now been successfully eliminated. So, you have to know about trachoma for your exams. So treatment for against chlamydia, topical tetracycline eye ointment 2 to 3 times a day or azithromycin eye drops. So remember tetracycline, azithromycin. Systemic is also needed. Obviously, if it's an oculogenital infection, you would need something systemically also, and that would again help in the resolution of the eye infection as well. So systemic tetracycline again, or doxycycline or erythromycin. So either tetracycline or macrolides. Avoid tetracyclines in young children and lactating mothers. Obviously, you know that, and this particular group of patients would need azithromycin as a single dose, or ofloxacin can be given. So that is the treatment for chlamydia. Okay. Coming on to viral conjunctivitis, more common, very very common. I'm sure all of you may have had an episode at least once in their life. So usually follows a systemic viral illness. It is also seasonal, because viral illness itself is seasonal. Now, follicles are very, very characteristic of viral conjunctivitis. Okay. So, the inset, this picture shows a congested eye. This picture over here shows follicles. There are the contrast is poor, but there are follicles. If you see carefully, you can see whitish dots, white circles like these over here. Okay, so those are follicles. And here in picture B, this is showing a superficial corneal involvement. So sometimes it may involve a cornea, and in that case, the patient is going to have photophobia as well. So this is a very superficial punctate keratitis. Okay, you see there are punctate infiltrations on the superficial cornea. Okay. Now, epidemic keratoconjunctivitis. This is the most common type of viral conjunctivitis caused by these serotypes of adenovirus. Then these are some other types. They're mentioned in your books, so you can go through these. And I think for this is important for Viva point of view about they can ask you pharyngoconjunctival fever is caused by, Newcastle is caused by, hemorrhagic conjunctivitis, which is also common, is caused by Coxsackie virus and enterovirus. So it is important to try to remember the serotypes, the numbers. So treatment of viral conjunctivitis, there is not much you can do. It is a self-resolving illness. And lubricating eye drops plus antibiotic eye drops to avoid bacterial superinfection. And in cases of herpes, you have to give topical acyclovir if there is corneal or skin involvement. Okay. Now, that was about acute. Coming to chronic infectious. For chronic infectious conjunctivitis, you only have to read up trachoma. So, major cause of blindness in the developing world still is endemic in several countries. Endemic in India until last year, and last year it was eliminated. So, it is caused by an intracellular parasite. Some may call some like older books classified chlamydia as a bacterium. Some recent books classify it as a parasite. So that's okay. You can call it. It is basically a protozoan, right? So chlamydia trachomatis and chlamydia psittaci. Okay, these are the just two species. What are the predisposing factors for trachoma? Now we're reading about trachoma now. Okay, so predisposing factors: children, females are at a higher risk, and poor general and ocular hygiene. Symptoms: pain, lacrimation, photophobia, and later blurring, and finally loss of vision. Now trachoma has a great tendency to cause scarring. So that is why blurring and finally loss of vision. Because you might wonder that it is just a conjunctivitis, no? So why loss of vision is happening? The loss of vision is because of its sequelae. Trachoma, if timely, adequately treated, resolves wonderfully without leaving any scars or anything. But the problem is that it is not treated on time and it festers. And then it goes on to cause fibrosis, which is responsible for such blinding sequelae we'll be seeing in the subsequent slides. So acute trachoma is going to cause conjunctival congestion, papillary enlargement. So here you can see papillae. Okay, these are papillae. See, the congestion will be there. These are papillae. All right. And development of follicles, both papillae and follicles, usually in the upper tarsal conjunctiva. They are more, both the inflammatory reactions are more common in the upper tarsal when compared to the lower tarsal conjunctiva, and it undergoes a kind of scarring. Sometimes you may actually see a white line when you evert. You might still see in some old patients of trachoma where the scarring has happened. When you evert the upper lid, you see a whitish fibrotic band, and that is known as the Art's line. There is one arched line in ophthalmology and there is one arched triangle. Okay, I'm not going to tell you what arched triangle is. I expect you to know, else we'll cover it in uveitis. Okay, now if the corneal involvement happens, what happens? There is a pannus formation. You can be asked in your viva what a pannus is. You can get it as a short note. So a pannus is nothing but a lymphatic infiltration, WBCs, infiltration along with vascularization. So it is leukocytes, okay, plus blood vessels. Okay, that is a pannus and usually limited to the upper half of the eyeball. So follicle-like infiltrations may sometimes appear. Pannus is one. Okay, another thing is Herbert pits. Now, Herbert pits are when the follicle-like infiltrations are happening here, and then these infiltrations undergo fibrosis and result in the formation of pits here, like these. Okay, so they are known as Herbert pits. Then superficial vascularization of the cornea. You should know the difference between a progressive and a regressive pannus. Now see, in a progressive pannus, it is still progressing as the name suggests. So the blood vessels, are going to, go up to a certain horizontal line, and beyond that line there will be infiltration. Whereas in the case of regressive pannus, there has to be signs of regression. So by regression, the blood vessels have regressed. The infiltration still remains. So the the infiltration would be behind. Okay, they would not be beyond the blood vessels, but behind the blood vessels, because there is regression, right? So the inflammation is regressing. So just the old blood vessels remain. So progressive versus regressive pannus. Now this differentiation is important because a progressive pannus would require treatment. And shallow corneal ulcers can occur at the edge of the pannus. So these are the sequel. See, blinding corneal scar, ptosis, entropion. Mostly a lot of lid scarring happens. So ptosis, entropion, trichiasis, tylosis. So how do you diagnose? These are laboratory tests, but then the WHO gave a very easy clinical diagnosis, which is known as FISTO classification. Okay. So the FISTO stands for these, and that is the clinical diagnosis given by WHO. And again, another good mnemonic to remember the treatment for trachoma. So safe strategy. S, surgery for entropion and trichiasis. A, antibiotics. F, facial hygiene. E, environmental hygiene. Antibiotics, what antibiotics? Tetracycline 1% ointment or azithromycin. So again, tetracycline or macrolides, we already saw that in the previous slides. And systemic or single oral dose of azithromycin 1 gram is also effective. Okay, ophthalmia neonatorum, another short note, very, very important. I told you that follicles are not seen in case of in case of neonates, okay? Because that lymphoid layer is not developed. So presence of any follicles, presence of any discharge, any kind of discharge from the eye in the first month of life should be viewed with suspicion. See, any discharge, even watery, from a baby's eyes during the first, in fact, it is month, should be viewed with suspicion, since tears are not secreted so early in life. That is one. And follicles are also not formed in the first month of life. Okay, so you will not see follicles in neonates. So neonatal, the definition of conjunctivitis is this. Neonatal conjunctivitis is defined as a mucoid, mucopurulent, or purulent discharge from one or both eyes in the first month of life. Now, the definition is That is all the definition is. It does not include the word watery, but know that even watery discharge should be viewed with suspicion, even it may not turn out to be an infection. Differential diagnosis of discharge from the eye: blocked NLD, acute dacryocystitis, and congenital glaucoma. So, according to the time of onset after birth, the differential diagnosis, one can point out the organism likely to be involved. And since it is an ophthalmic emergency, there is no time to go and do a culture and wait for the culture results. We start an empirical treatment, okay, based on the mode of, based on the presentation. See, in the first 48 hours, Neisseria gonorrhoeae, you give ceftriaxone. Okay, chemical conjunctivitis, wash eyes, apply erythromycin, and observe. This used to happen earlier because when the baby, when there was something known as Creed's method, in which silver nitrate was instilled into the baby's eyes at the time of birth to prevent infections. But then turns out that it caused more harm than good, and it would lead to a chemical conjunctivitis. So it's not no longer seen as of historical importance. Then, if presenting within 48 to 72 hours, it is other bacteria such as streptococci, etc. I told you about there were so many bacteria. So this is the treatment. Okay, a very simple treatment, right? Neomycin and bacitracin eye ointment, which is available as a cheap over the counter ointment. So then after that, 5 to 7 days, herpes simplex. Again, acyclovir is also very widely available. Systemic acyclovir, if required, should be given in consultation with a pediatrician. And if happening after a week, you should suspect chlamydia trachomatis. Okay, you know the treatment about of chlamydia trachomatis. Wherever systemic treatment is required, you have to consult a pediatrician. And serious sequelae, if left untreated, because Neisseria, which is the most common one, can penetrate, is one of the organisms that can penetrate intact corneal epithelium, right? So if the cornea is invaded in ophthalmia neonatorum, there is going to be a scar. And a scar in case of a child is a very, very serious thing, because if it happens in the visual axis, it's going to cause amblyopia to the child. So some that's about acute and chronic infective conjunctivitis. Coming on to non-infective conjunctivitis. So allergic conjunctivitis, these are several varieties. The clinical features of all of these overlap, okay, except for FLIC10. The clinical features are going to overlap in all of these conjunctivitis because all are mostly type 1 hypersensitivity reactions. Just the names are different, but then the treatment and the clinical features are all overlapping. That is why I have grouped everything under allergic conjunctivitis. After allergic conjunctivitis, there are certain systemic disease associated conjunctivitis, and these kinds are usually chronic. So what systemic disease? Stevens-Johnson syndrome, Rita's disease. Rita's disease has a triad, you should know about it. Behçet's disease, which affects most of the mucous membranes. Sarcoidosis and ocular cicatricial pemphigoid. So some systemic disease associated, there will be systemic features also. And then, of course, toxic and chemical conjunctivitis. What toxin? Some irritants, some drugs, and even lice on the eyelash can lead to a inflammation, that is conjunctivitis. So of the allergic variety, we are going to discuss one, that is Spring-Catarrh, which is the most important. Now, the name itself is a misnomer because it actually happens in summer and not winter, and not spring exactly. So it's a misnomer. But then nothing is hard and fast in science, okay? So just remember that the name has historical importance, Spring-Catarrh, okay? So recurrent bilateral conjunctivitis occurring with the onset of hot weather, more common in adolescent boys. It is a type 1 hypersensitivity reaction. So in case of Spring-Catarrh, it is a type 1 hypersensitivity reaction to the atmospheric temperature. It could be from other things also, like pollen, animal fur, or certain flowers, okay? And the symptoms would be intense itching. Now this is a common symptom of allergic conjunctivitis, intense itching. The patient actually comes with the first complaint is intense itching. So redness, watery secretion, and a white ropey discharge. Now what do you see here? You see giant papillae. These giant papillae are also known as cobblestones, okay? And what do you see here? You see that there is some mucinous thickening of the limbus here, okay? And sometimes this mucinous thickening assumes the formation of white dots, and these are known as Horner's, Trantas, spots. Again, important for your Viva. See, signs: redness, lacrimation, large papillae. These are the cobblestones, and lid swelling, and nodules or gelatinous thickening at the limbus. And these actually consist of eosinophils, epithelial debris, and they are known as the Horner Trantas dots. Then, in chronic cases, this was all of this is acute. In chronic cases, you will see that the eye in general looks muddy. So muddy discoloration of conjunctiva, and you can also have corneal vascularization. Keratoconus, why keratoconus? Because of repeated rubbing of the eye due to the itching, there happens a change in the curvature of the cornea. It would lead to, protrusion. There is so much of rubbing that the cornea actually begins to protrude, leading to keratoconus. So treatment is in the form of anti-allergics. So that includes all of these: mast cell stabilizers. You've read all this in pharma. Decongestants, preservative-free lubricants are needed. Why preservative-free? Because preservatives like BAK, oxychlorocomplex present in eye drops itself cause inflammation. If very severe, you might need mild steroids and topical cyclosporin. Then acetylcysteine. Now, this acetylcysteine is a mucolytic. Okay, remember there is a lot of mucus. That is why that ropey discharge happens. So sometimes the mucus is so much that you will need a mucolytic, okay, to clear the excess mucus. So that is acetylcysteine. Watch out for side effects of chronic use of steroids, of course. Shield ulcers. Now, shield ulcers are formed secondary to allergic conjunctivitis. Remember, so shield ulcers would need management, additional management, such as I think we discussed in the treatment of non-healing corneal ulcer. They are non-healing because the irritant is acting as a stimulus. It is there. So they might need BCL, cyanoacrylate glue, fibrin glue, sometimes even grafts, right? I think we discussed that corneal ulcer. So I expect that you remember. And cold compresses and tinted glasses are for comfort. Then some degenerative conditions of the conjunctiva. Um, all of you know about pterygium, all of you know pinguicula. So just a definition here for you. A triangular encroachment of vascularized granulation tissue covered by conjunctiva in the interpalpebral area. Triangular. See, this is the shape, okay? And the name itself suggests pterygium. The word pterygium means wing. So it is shaped like a wing, okay? It almost looks like a wing. And it encroaches upon the cornea and destroys the superficial stroma and Bowman's membrane. So since the Bowman's membrane is destroyed, you always warn the patients when removing pterygium, we always warn the patients that it might leave an opacity on the cornea. Okay, you have to tell the patient about the prognosis always. It causes corneal astigmatism. Okay, there's something on the surface of the cornea, so it is going to change the shape of the cornea, right? Normal shape is like this. If so, there is something, it's going to change the shape, and it is going to cause some astigmatism. Common in dry, sunny climates, and UV light is probably a cause. Okay. Uh, so the second picture, this is not a pterygium, okay? This is basically a pseudopterygium. There is something known as a pseudopterygium. It is nothing but fibrotic tissue that has encroached, conjunctival tissue only, that has undergone some fibrosis and encroached on the cornea. So this is a pseudopterygium. How to differentiate? If you differentiate by the probe test, you can take a simple lacrimal probe. So a lacrimal, this can be asked to you in your viva. So listen carefully. If you take a lacrimal probe and you try to insert below the pterygium, it will pass through because pterygium is a growth. It has a head, neck, and a body. Whereas this, you cannot pass a probe underneath. Okay, it is sticking to the cornea and there is no space in between. So that is a pseudopterygium. Okay. Other degenerative conditions include concretions and pinguicula. Pinguicula is often said to be a precursor to pterygium. So this is basically surgical steps showing the removal. So basically, you grasp it from the head and then you shave it off the cornea. You shave off this cornea completely to remove all remnants, and you either leave it, you cut the head of the pterygium. After shaving off, you cut the head, and you can leave the bare sclera, or you can take an autograft, that is a small part, a section of the conjunctiva, and graft it over here. This is done to prevent recurrences, and these things are sutured. Okay. So conjunctival cysts and tumors, these are the benign ones, and these are the malignant ones. This is just for your interest. I don't think they could, if at all, they can give you a short note, or maybe if you have your spotters. So this is a dermolipoma. Then this one is a nevus. And now the next slide that I'm going to show, see, compare. This is a nevus. It is localized, right? And look at this. This is actually malignant melanoma. See, it is spreading everywhere, and see how vascularized it is, and see how it is distorting the architecture of the of the cornea. So, characteristic features of a malignant tumor. Lastly, xerophthalmia. Again, you can have it as a short note. So, the xerophthalmia that happens because of deficiency of fat soluble vitamin A in the diet. That is just one of the xerophthalmias. Okay, the word xerophthalmia means dryness of the eye. So what happens is that small foamy dry triangular white patches on the outer and the inner bulbar conjunctiva here. This is a foamy looking patch. The foamy appearance is because gas is produced from Cornybacterium xerosis. Okay, Cornybacterium xerosis flourishes in the conjunctival sac. Vitamin A supplementation would be needed if it is because of the deficiency of fat soluble, but then the xerophthalmia can also occur secondary to the following chronic conditions. Just to summarize, we've read about acute bacterial conjunctivitis, trachoma, that is chronic bacterial conjunctivitis, VKC or spring catarrh. It is also known as VKC. Okay, flictin. We read about flictin in the last class on cornea. I described the flictin and I showed you what a flictin was. So remember that. Xerophthalmia, ophthalmia neonotorum, very very important. Pterygium and how to remove a pterygium also. You should know the basic steps of removal of the pterygium. Okay. So that is the summary, and that's about the class today. And thank you very much for watching.
Thank you, ma'am.